think the topic that we'll discuss today is one of the most important topics and most important steps in the IVF cycles, and it's not given that importance and that concern. Same like the follicular phase and same like induction protocols and everything, but I think it's very, very important as it may be detrimental and may affect the implantation rate strongly, actually. At first, we showed though the natural fate of the human embryos. Actually, what about the fate of the embryos that will be put intrauterine during the ART cycle or IVF cycle? 25% will go for live birth rate, and 15% will start clinical pregnancy but will end by clinical miscarriage. So 40% will cause clinical pregnancies, but another 60% will not get clinical pregnancy, 30% of them with early pregnancy loss, and 30% unfortunately with implantation failure. What are the possible causes that may increase the ICSI failure rate? Causes at first is category 1 which is causes that can affect ovarian response and oocyte quality, which may include endometriosis, starting ovulation and induction without checking and adjusting the level of basic hormones and BMI, unsuitable ovulation induction protocol, genetic factor, which may cause premature ovarian insufficiency or anti-follicle syndrome. Category 2, causes that can affect the fertilization rate and the quality of embryos, which can include severe male factor, efficiency, and the quality control inside the IVF lab, which is very, very important factor. Category C or 3, which is causes which may affect the implantation rate of the embryos. We can see in bolded red cause, which is luteal phase defect, thin endometrium, just 1 second, give me 1 second. Okay, thin endometrium and uterine fibroids, adenomyosis, intrauterine synechia, high progesterone level in the early luteal phase, one day of the trigger, missing the window of implantation, inefficient IVF specialist, or many manipulations which may be done in difficult cases, and thrombophilia's risk. Category number 4 or D, causes that may lead to very early loss of implanted embryos, and it includes, actually this category includes also the luteal phase defects, again genetic and chromosomal problems, immunological and genetic factors, etc. The endometrium, this secret that we actually, all of us are trying to know and to discover in the last few years, in maybe last 5-6 years, in many conferences, and in most of the conferences, there is fixed session, fixed topic in all sessions, in all conferences, which is the endometrium, thin endometrium, luteal phase support, recurrent implantation failure due to endometrial factor, and many factors that can affect the endometrium. Endometrial thickness, defined as the minimal distance between the echogenic interface of the myometrium and the endometrium, measured in the plane through the central longitudinal axis of the uterine body. What about the accuracy? Different from 1 to 1. Discrepancy may reach 1 to 5 mm between experienced and non-experienced technicians and sonographers. Inter-observer 70 or 80 proteins, and mentioned 17 to 18 most important proteins in the endometrium that can affect the implantation. Blood flow, subendometrial revascularization measured by 3-dimensional power Doppler ultrasound or Doppler ultrasound. Multiple lines of evidence suggest that embryo endometrial synchrony is critical for implantation and successful pregnancy. No morphological assessment has been shown attention
voice please, Dr.
has turned.
Yes, okay.
Okay, what
Okay.
about, is it okay now?
Yes, okay now.
Can you hear me?
Yes, Waleed,
Attention
okay
has turned. Attention has turned to functional analysis, transcriptome, proteome, and metabolome. And actually, there are many centers all over the world. Genomics, which is the genetic center for IVI centers all over the world, and many other centers in USA, which are reporting now a detailed sheet from endometrial biopsy, can give you detailed sheet containing the transcriptome and proteome and metabolomic state of your endometrium and the recommended day and date of transfer per each cycle for each person. What about the physiological action of progesterone? It antagonizes estrogen proliferation effect, control of ovulation, decidual proliferation and decidualization, uterine vascular changes, endometrial preparation to nidation, هو تعشيش يعني, reduction of uterine contraction, immunomodulation for blastocyst implantation. The luteal phase is a very popular yet complex and poorly understood topic in the field of in vitro fertilization. After ovulation, the formation of corpus luteum occurs under the influence of luteinizing hormone. Studies in humans and primates have demonstrated that the corpus luteum requires a consistent LH stimulus to perform its physiologic action and physiologic function. In 1949, Georgina Jones was the first who described luteal phase deficiencies as the premature onset of the menses resulting from deficient progesterone production correctable by exogenous progesterone administration. The main etiology of the luteal phase defect observed in stimulated IVF cycles is the supra-physiologic levels of steroids secreted by high number of corporal lutea during the early luteal phase, which directly inhibits LH release via a negative feedback action at the level of the hypothalamic pituitary axis. If conception and implantation occur, the developing blastocyst secretes human chorionic gonadotropin, HCG. The HCG produced by the embryo will maintain the secretory activity of the corpus luteum due to the structural similarity between HCG and LH, thus activating the same receptors. Okay, here you can see the in this diagram or curves, you can see the progesterone concentration or the progesterone onset during normal cycles and during hyperestimulated cycles. In the left curve, you can see the hyperestimulated cycles. Accordingly, you can see the high peak and the high and the rapid onset in the progesterone level after triggering, but you can see also the rapid offset of the progesterone and rapid reduction of the progesterone level. But in the normal cycle, the peak is lower, but it's maintained in for a longer duration. Luteal phase support is mandatory in all stimulated cycles, and this is level A, level 1A evidence. HCG versus placebo or no treatment, higher ongoing pregnancy rate, higher clinical pregnancy rate, and higher live birth rate, significantly different. Luteal phase support can be done by different types of drugs. It can be done by HCG, by progesterone, which can be vaginal, intramuscular, rectal, sublingual, which unfortunately is not present in our country, the progesterone, recombinant LH, which is query as if we want to do luteal phase support by recombinant LH, we should give high doses, and unfortunately the available product from Merck company is short acting, so we will need higher doses, repeated maybe twice daily actually. Luteal support is in asset production. This was a survey done in many countries, and it showed that in more than 90% of gynecologists, the vaginal progesterone is the preferred method for luteal support, and in this 90%, 77% given as single agent and 17 in combination with intramuscular progesterone. Vaginal versus intramuscular progesterone in fresh cycles. Actually, this was a randomized controlled trial done in 2008 and another one in 2011, and it showed, as you see, that I will show you in my presentation different opinions and different debates. And this opinion in these randomized controlled showed that the data showed that the vaginal progesterone is not inferior compared to the IM progesterone. And the conclusion was that the clinical pregnancy rate and live birth rate and miscarriage rate was almost the same or non-significantly different from between the vaginal and the intramuscular progesterone, and with lower side effects and increased patient satisfaction and compliance with vaginal progesterone. What about the vitrified blood-assisted transfer cycles with the use of only vaginal progesterone replacement with endometrine have inferior ongoing pregnancy rate results from the planned interim analysis of the three-arm randomized controlled trials and non-inferiority trials, which was published in Infertility Sterility at the end of 2017, and it was very important randomized controlled trials actually, as it showed and compared between three arms in randomized controlled trials between the vaginal, in vitrified thyroid cycles, in between one arm given only vaginal progesterone and the second arm given IM injections, progesterone injections, and the third arm which was given combined vaginal plus every third day IM injection. Actually the conclusion was that relative to regimen inclusive of intramuscular progesterone, vaginal only progesterone replacement for vitrified hormone plus assisted transfer results in decreased ongoing pregnancy due to increased miscarriage and should be avoided. Vaginal decrease the pregnancy rate due to increased miscarriage and should be avoided. Randomization to the vaginal only arm was terminated. Can you see this word? This arm has been terminated with these findings. The arm of vaginal only progesterone in vitrified thyroid cycles was terminated and stopped due to decreased live birth rate and increased miscarriage rate. Another publication by Labarta et al. 2017, in a recent cohort study, examined progesterone serum level on day 7 of the administration of 800 mg milligrams daily of vaginal progesterone, the day of placenta transfer in women receiving donated oocyte in anovulatory. Why they have chosen donated cycles to be neutral and to avoid any effect of corporal lutea from induced ovaries. They used the donated cycles, the egg donation cycles, in anovulatory cycles, which they called artificial cycle. It was found that 25% of the women had serum progesterone level below 9.2 nanogram per ml, and that the ongoing pregnancy rate was markedly reduced in those patients. Multivariate analysis identified serum progesterone in this context as an independent predictor of pregnancy likelihood. If this finding is externally valid, we have likely been sacrificing numerous pregnancies over the years in oocyte donation program in which only vaginal progesterone has been used for endometrial preparation in programmed artificial cycles. Great caution must be exerted when extrapolating luteal support study finding from one scenario, fresh controlled ovarian hyperestimulation cycle, to another scenarios, an artificial cycle. Artificial cycle, same like the artificial cycle in frozen thaw cycle, for example. Without doubt, the different luteal phases need further study. A number of preparations are available to the reproductive endocrinologists for that purpose, including more recently subcutaneous progesterone and oral dydrogesterone. Both have been tested in large IVF randomized controlled trials, although only in the context of fresh cycles. Our patients exhibit marked inter and intra-individual variations in ovarian activity and endocrine parameters. This likely also holds true for the luteal phase, implying that we need to consider monitoring luteal phase hormone level in the future, especially under more critical circumstances after an agonist trigger and in artificial, for example, like after agonist trigger or in artificial cycles like in vitrified thaw cycles. Certainly the luteal phase has not been received, had to receive the attention that we have put on the follicular phase in ART that we must change. What about the E2 with progesterone and versus progesterone only luteal phase support? This actually was randomized controlled, published in Human Fertility in 2016, and as you see here, it shows that there is no significance. If you can see the last column, which include the p-values, you will find all of them insignificant, 0.3, 0.1, 0.2, 0.4. Accordingly, the pregnancy rate and the ongoing pregnancy rate and implantation rate, early pregnancy loss rate, all of them insignificantly affected in the two arms, the one with E2 plus progesterone and the other one with progesterone. So no rationale behind giving E2 in luteal phase support. What about the modified luteal phase support after GnRH agonist trigger? As my colleague and professor, Dr. Hisham Saleh, and my elder brother just mentioned that we should modify our protocol of luteal phase support if we will trigger by agonist. There is European and American school regarding this issue. One of them supporting and advocating giving HCG as dual trigger, which is the American school, as dual trigger, giving both agonist trigger plus HCG 1000 or 1500 in the same day, 10-15 minutes between each other. This is the American school. The European school advocating and supporting the rescue HCG, which is giving HCG as rescue dose 1500 on the day of oocyte retrieval, 35 to 36 hours after agonist trigger. Another opinion supporting only giving aggressive luteal phase support, intramuscular injections and vaginal progesterone plus E2 3 times daily, 2 milligram estradiol valerate 3 times daily at least. Another opinion supporting giving daily low dose of HCG, but for sure this will carry a high risk for ovarian hyperstimulation syndrome. What about the oral progesterone? Simple to use. Drawbacks including first pass hepatic metabolism. Maxon in 1984 mentioned that there is low bioavailability of oral micronized progesterone if it will be given orally. DeVroy in 1989 mentioned in 2 publications that it has poor results. But in very recent publications by George Griesinger in 2018 and 2019 in Notice 1 and Notice 2 mentioned that there is similar pregnancy rate from dydrogesterone. I think we need more larger randomized controlled trials and this should be warranted. Dydrogesterone use has been used worldwide since 1960s for a number of conditions related to progesterone insufficiency. It is estimated that cumulative exposure for all indications since 1960 to 2020 maybe more than 130 million patients have been exposed and given the dydrogesterone. Of those, it is estimated that more than 20 million pregnancies were exposed to dydrogesterone, which means that it's totally safe. Can be used dydrogesterone for luteal phase support or dysmenorrhea and treatment of endometriosis, secondary amenorrhea, irregular cycles, dysfunctional uterine bleeding, premenstrual syndrome, threatened abortion, habitual abortion, infertility, and hormone replacement therapy. In Lotus 1 study design, it was double-blind, double-dummy randomized multicenter studies done in 7 countries actually. And it showed it was non-inferiority randomized controlled trial, and the primary outcome was pregnancy rate defined as the presence of fetal heartbeats at 12th week of pregnancy. And it showed that that oral dydrogesterone was non-inferior to micronized vaginal progesterone for the presence of fetal heartbeats at 12th week of gestation, and also demonstrated that it was totally safe in these patients. What about the subcutaneous progesterone? Is it effective and safe for luteal phase support? This was meta-analysis done in phase 3 trials, and the objective actually was giving patients vaginal administered progesterone and subcutaneous progesterone and comparing forms as luteal phase support, and the subcutaneous progesterone was given in the dose of 25 milligram daily versus either progesterone vaginal 90 milligram or 100 milligram intravaginal twice daily. And the conclusion was that no statistical significant or clinical significant differences exist between subcutaneous and vaginal progesterone for luteal phase support. Role of gonadotropin releasing hormone agonist, the human chorionic gonadotropin, progesterone and estrogen and luteal phase support after HCG triggering, and when in pregnancy hormonal support, and this can be started and stopped. And actually this was published by Dominique Deziglé, the great professor in Paris in France, published in 2019, and it mentioned that the need of luteal phase support in ovarian stimulation using HCG for triggering ovulation has been amply documented. This is due to effective functioning of the anterior pituitary, lack of proper LH pulsatility, which interferes with luteal function after the effects of exogenous HCG vanish. There is a gap, as Professor mentioned, which we can call luteal gap. A luteal gap between the end of the effect of the exogenous HCG given for triggering and the onset of the endogenous HCG production, during which luteal phase support must be provided. This purported pathophysiology of the luteal phase in ovarian stimulation is an agreement with the fact that phase support is not further necessary for after positive pregnancy test is achieved. Luteal phase support is classically provided by exogenous progesterone administered either vaginally or injections intramuscular or subcutaneous, or in a new techniques, subcutaneous injections. Emerging new options are providing encouraging preliminary results for more user-friendly and possibly more efficient luteal phase options, which include microdose HCG preparations and daily, possibly transnasally, which unfortunately we cannot find in our country, which is the superfact transnasally LHRH agonist. This figure can show the luteal gap, which you can see in between the left side and the right side. The left side is the endogenous HCG, which can be given for triggering, and it can last. If you can see in the figure, in the diagram, it can last in the red bolded thick red line in the left side, and after the drop of this level of HCG, there is a gap in between it and the other line, which is the beta HCG produced after implantation. And during this gap, the risk is very high, and the risk of loss of implantation and risk of loss of the very early loss of implanting embryo is very high actually. The next question is when to start luteal phase support. The defect to be corrected: deficient progesterone production as a result of lack of LH support to the corpus luteum. This defect, which be corrected, only starts several days into the luteal phase. During the so-called luteal gap, there is, therefore, it could be considered that luteal phase support might be initiated only a few days after oocyte retrieval. In fact, the concept that early progesterone administration could harm by advancing the closure of the window of the receptivity has been advocated in the past, but nowadays this has been vanished. Conversely, arguments have been put forth for initiating progesterone supplementation on the day of or the day after oocyte retrieval for suppressing uterine contractions at the time of embryo transfer. We have shown that the frequency of uterine contractions, which can start very early due to very high level of E2 on day of cleavage stage, was inversely related to pregnancy chances. In further trials, we showed that increased uterine contractions resulted from some degree of resistance to the uteroquiescent effect of progesterone brought about by the very high E2 level encountered in ovarian stimulation. This effect of early onset of luteal phase support may be of less relevant in case of blastocyst transfer, as we have a good gap 5 days after oocyte retrieval. Accordingly, the uterus can go in a quiescent and relaxed state. When to stop luteal phase support in fresh embryo transfer cycles? Some persons, some papers mentioned that it can be stopped in the day of pregnancy test, which would be positive. Nebu mentioned that in 2002, Goj in 2011, another opinion to be stopped in first transvaginal ultrasound. Professor Balghar in 2008 published randomized controlled regarding this issue. Another opinion at the end which mentioned that we have to stop at the end of the first trimester. It has been common practice to pursue luteal phase support until approximately the 10th week of pregnancy, when the luteus placental shift is ascertained. Beyond the time, corpus luteum function is not necessary to development of pregnancy, as shown by ovariectomy data. This study was done in ovariectomy patients, so there is no effect at all for any corpus luteum or any ovarian progesterone. Experience from pregnancy developing in women whose ovaries are absent or plugged in donor egg ART confirms that there is no need to pursue luteal phase support any longer after beta HCG positive. On the contrary, there is mounting evidence that in regular ART, luteal phase support can be discontinued earlier than the 10th week of pregnancy. In the prospective randomized controlled trial that Professor Balghar et al. Unequivocally showed that luteal phase can be stopped at the time of the first ultrasound performed 2nd to 3rd week after the positive pregnancy test. Furthermore, others have shown that luteal phase support can be harmlessly stopped at the time of positive pregnancy test. A meta-analysis of studies evaluating the duration of progesterone administration after a positive pregnancy test found no influence on the miscarriage or delivery rates when progesterone applications was continued or discontinued for 2 weeks after a positive pregnancy test. The increase in the endogenous HCG level during early pregnancy makes up for any lack of endogenous LH that was caused by stimulated IVF cycles, so progesterone administration can safely be stopped on the day of positive HCG. A very important note, the situation is obviously drastically different in frozen embryo transfer cycles, especially in artificial cycles, while we are preparing our endometrium by E2 and to be followed by progesterone vaginally or intramuscularly. These artificial cycles, the situation is totally different. In that case, there is no corpus luteum in principle, and therefore hormonal treatment has to be pursued until the luteal placental shift, which should be continued till the 10th to 11th week of pregnancy. In conclusion, luteal phase progesterone supplementation is mandatory in all IVF cycles. Different routes of progesterone administration. A vaginal route is as effective as intramuscular route and is better tolerated. This is one theory. Another theory, as I mentioned that vaginal route only is inferior in having lower clinical pregnancy rate and higher miscarriage rate compared to the IM route. When the agonist is used to trigger the ovulation, the standard luteal phase support is inadequate and it must be modified by HCG use, or freeze-all strategy has to be applied. In frozen embryo transfer cycles, there is no evidence to support the use of one cycle regimen in presence or to another. In the modified natural cycles, progesterone supplementation might be not necessary. In the modified natural cycle, again, when we will give we will follow up the follicle and we will give trigger by HCG, then we will have corpus luteum. Then we are not obliged to give progesterone supplementation for luteal phase support. But in artificial cycle, while we are using estradiol followed by luteal phase support, we should use progesterone as supportive method because we don't have in these cycles any corporal lutea. Combining oral progesterone with local vaginal progesterone may have a role in decreasing post-embryo transfer vaginal spotting significantly and achieving chemical and clinical pregnancy rates non-inferior to combined local and injection double luteal phase support. And personally, this was my experience, and I used this, and actually I noticed a decrease spotting during the waiting period after embryo transfer. Still, we need more randomized controlled trials to test the potency of oral progesterone in double-line luteal phase support, combined oral and vaginal, besides its role in efficacy in different protocols of frozen thyroid cycles. Finally, we need more studies to compare different protocols of luteal phase support in agonist-triggered fresh ICSI cycles, while the luteal phase support is totally depending on the exogenous source of progesterone, as we don't have these cycles endogenous progesterone due to the luteolysis, as Professor Hisham mentioned in his presentation.